Dear Germans, ladies and gentlemen, I would like to share with you some information about VasQ system-based vascular access creation, complicated in time-based stenosis near anastomosis, and the treatment possibilities. The typical filar mode for fistulas occurs in the juxta anastomotic region, where we have dissected and mobilized the vein. The surgery removes this section of the vein from its native supporting tissue and introduced multi-direction flow, oscillating wall shear stress, and increased wall tension. All of those factors can trigger the remodeling in this area. The VasQ device was designed to promote maturation through optimized hemodynamics and mechanical support. The device is made up of a woven nitylon brain and a laser-cut nitylon brace. It's implanted around the GAR during fistula creation. The surgical images show the device in place prior to completion of a creation surgery. You can see the brace sit on the artery at the anastomosis, and the brain provides support for the first 3 centimeters of vein. I have implanted 24 VasQ devices to date with excellent results. My patients are primarily male with half forearm and half upper arm, including 4 RCF proximalization cases. No complication associated with the procedure. 4 patients had successful PTAs of stenosis, and 1 occlusion required a surgical revision. The resulting maturation rate by 12 months was 96%, with 93% of the patient requiring dialysis able to use the VasQ access. Primary patency was 83%, with 96% of patients retiring secondary patency. One of the questions about VasQ is what options are available to you to restore patency in the rare occurrence as stenosis occurs at the anastomosis. In my patient cohort, I have been able to successfully for PTA for patients, including within the anastomotic region, as well as performed a patch angioplasty. This is a case example for a patch angioplasty, which is first to be shown to date. The patient presented as 84 years old female with BBF performed in November 2020 with flow volume of 450 milliliter per minute at the first day after the operation, and 750 milliliter per minute, and diameter of vein 7 millimeter after 1 month after operation, and after 4 months after the operation, we saw the patient again with flow volume 250 milliliter per minute, and diameter of vein 4 millimeter. We have detected stenosis in the anastomosis and decided about superficialization of and surgical transposition of basilic vein and endovascular correction of anastenosis in 1 operation. So you can see here This stenosis observed at the GAR region. It's intraoperative contrast study of the fistula via brachial artery, and we switch on to retrograde intervention via vein. And unlikely the prior PTA cases, I was able to cross the stenosis with a wire, but not with a PTA catheter. I have decided to convert to patch angioplasty with transposing the vein. When the device was exposed, you can appreciate the level of tissue incorporation without signs of inflammation. This is expected with nitrilon-based devices as they are rare bioinert. So, despite the presence of the device and tissue incorporation, I was still able to disrupt wire mesh using surgical scissors and place a patch in the juxta-anastomotic region, as you can see in this image. I was able to cut the brain with surgical scissors without issue. The patch could be sewn in the GAR in the presence of VasQ using standard technique. Final flow rate was 650 milliliter per minute with diameter of vein more as 6 millimeter. The patient is doing well. Conclusions. Using a VasQ system per the IFU is safe and may reduce risk of anastomotic stenosis in AV fistulas, improving fistula patency and usability. Case example shows the ability to use standard techniques including PTA and patch angioplasty to restore patency in the rare occurrence of stenosis. This system should become the standard of fistula creation surgery. Thank you for your attention.